for the yeah, so when I do it, I'll see my students.
Oh, okay. No, I only
You
can
can
see.
see the Collegiates.
I think it's
Yeah.
Okay, so that's technically going to a
yeah,
Okay.
I can give you. I'll do that.
Yeah.
Like STDs.
Usually, a regular seminar room does have a clock.
Yeah.
Okay, so
Totally.
perfect. All right.
You got There's nothing to do with the
You're gonna be like,
I have another day after that.
Okay, thank you.
Jeff, would you mind closing the door? Just so we love our outreach to the high school students, but not that much. All right, thanks everyone for attending. Today we're visited by Julie Ivy, who's the chair at the IOE department, right? In Michigan.
Yes.
Yeah, it's everyone has a slightly different spin on industrial engineering. Julie is both an Informs Fellow and an IISC Fellow. She's a very illustrious career. She's also a board member of the National Academies of Mathematics and Analytics. Julie's done a lot of great work in healthcare, and especially looking at the intersection of healthcare with complex societal issues, and has done a lot of important work also with Minority Issues Forum at Informs, where she's also been a fellow of Minority.
Yeah.
There's very few things I guess you're not a fellow of, which is good.
There's just
And she's here today to talk to us about some of her recent work in healthcare. So let's give a warm welcome to Julie here.
Thank you so much for having me. I'm excited to be here. I was saying last time I was here was a number of years ago. Here at Nim Harvard's on your faculty, so that gives you some idea that it was a little bit. So I'm really excited to be here. So thank you for having me. Today I'm going to talk a bit about a couple of projects that I've worked on and looking at the way, kind of using them illustratively to look at this idea of moving from data to decision making and some insights. There's, I feel no problem with critiquing my own work, so there's lots of opportunity, right, for future direction and things. So these are kind of motivational. I like to start with telling you a little bit about myself, because that kind of frames the way that I look at the world and the way that I approach problems. I am originally from Detroit. I spent most of my life in Detroit and spent some time in Ann Arbor. I always like to show the more Ann Arbor-ish looking picture versus the University looking picture, because I went to parts of elementary there and actually graduated high school from there. I bleed maize and blue. I went to my bachelor's at Michigan and my Ph.D. I like to say that I bleed maize and blue also because it kind of runs in my family a little bit. So my father, who was much older than my mother, like as in he was born in 1911, he graduated from University of Michigan. He was one of 9 Black students on the campus at the time. And so it kind of is a relationship that really is pretty close in my family. I always put my sorority up there because it's a social justice organization. It frames the way that I look at the world. I have a master's from Georgia Tech, so I have a little bit of yellow jacket in me. A little bit dominated by the blue part, but the yellow kind of goes in common. I think of myself as an industrial engineer. And so that means that it frames how I look at the world. Like I think about things as being interconnected. I think about systems. I think about the way that the human actually is centered in those systems. And those things frame kind of how I approach the world. I do a lot of work in healthcare. I also do work in humanitarian logistics. So we'll talk about that. And I tend to take an operations research perspective. So my community of practice is the Institute for Operations Research and Management Science. And that kind of frames the way that I look at the world and the way I look at problems. I also like to put my department a little bit, so since I'm also wearing 2 hats. So we're the number 2, and we've maintained that, just released earlier this week. Number 2 graduate program, number 3 undergraduate program. We have about 450 undergrads, just about 250 graduate students. We have an amazing faculty. Some of you are colleagues with them. They're really amazing people, both in terms of their research, but also their character and the type of people they are. And we have a very large alumni network. I think it says over 10,000. I think we're approaching 15,000 living alumni. Our faculty do work in a broad variety of areas, similar to yours. data analytics, human systems integration, optimization, stochastic systems. And then we have several people who do work in healthcare as well as business operations. A number who look at transportation. Michigan has a thing called M-City that we're involved with, and then energy and sustainability. I'll talk about a couple of faculty who actually gave me their slides. So Salah Fati, I think some of you know him. He's one of our junior faculty. He does a lot of work looking at the underpinning in terms of optimization that makes machine learning and AI work. He has a recent career award around this, and then he's also done work where, as part of that award, he's worked with students at local high schools, IPSI and in Detroit, introducing them into AI. So they have a thing called AI Venture that they do to kind of introduce students and expose them to IE. Ocean Tyagi is one of our newer assistant professors. She joined last year with me. She does work that's at the intersection of cognitive and physical ergonomics. In particular, she looks at things like the impact of stress, both physical, neuromuscular stress, physical stress on the neuromuscular fatigue. She looks at it with respect to older adults. She also has done some work where she looks at it with respect to EMTs, so people who are in stressful work environments, and then how that impacts their cognitive function. In particular, kind of thinking about this association between the exoskeleton and neurophysiological costs for EMTs. Weiwei Zhang is one of our associate professors. He does work in stochastic optimization. In particular, he's been doing some work related to energy and grid optimization and the planning grid or power grid. Eli Liu is another one of our senior ergonomics faculty. His work is interesting in that he develops kind of a queuing network modeling framework to represent human behavior and cognitive function. This work has been used with respect to vehicles and human interaction with Ford. Now, that's a little bit about some of our faculty. I'll tell you a little bit about my work. In general, I work on problems that I like to think of as human-centric. I like this quote by Zimmerman when I think about how I think about the world, right? And that, if I think about things around health inequities, it's really a function of the environment that people are born, work, and live in, and the structures that inform that. I do work in kind of 4 dimensions. I'm going to talk about some of the work that I do in healthcare that's kind of at the intersection of care delivery and medical decision making. I do work in wealth, specifically the lack thereof of wealth, and I look at hunger relief. And I'll talk a little bit about some of the work where we've been working with food banks and thinking about distribution decision making. And then I also do some work in education, specifically looking at student performance and trying to predict things like dropout for engineering students, and then thinking about how to optimally intervene. All of these problems have this fundamental concept of the human that's in the center, and these relationships at this interpersonal, organizational, the community, and policy that influence the outcomes for those humans. And so if we can kind of take this interconnected view of that world, that's kind of, I think, what my work seeks to do at different levels or stages of work. All of the world I think of as uncertain, where that uncertainty evolves under time, and I look at everything from a decision analytic framework. So how do we use data or decision to inform that? And I like Markov models and all their different flavors and forms. I like their structure. They're my friends in some ways, sadly. And then I do some work in simulation and some Bayesian work looking at kind of this idea of how we learn over time. Everything is looking at this idea of personalizing to the needs of the individual and defining at what level can we do that. And I'll start by talking about learning from data. Data, as always, you ever heard me talk, you probably heard me say this, it's a blessing and a curse, right? You want data, but you never get the data you want. You get the data that's there. And so that data is there's time series, longitudinal, sparse at the same time, and we'll talk about this in the sepsis work, where it seems like at the beginning a whole lot of data that somehow narrows down to a very small bit, and the more detailed we get. Quantitative, qualitative, coming from various sources, and this fundamental idea of really trying to capture preference or understand preference, which we'll talk a little bit about the second study, And what can we learn from data with respect to that? All of this data, though, it's critical for us to be thinking about the context. Like, data really aren't numbers, but they represent people, and they represent aspects of people. Or in the food bank world, they represent communities and aspects about those communities. So in this world, there's this cycle, right, from descriptive to predictive to prescriptive that we're working through with this data. And that's kind of a goal or aspect of the work that we're doing. And this idea of going from learning from the data to actually starting to model. If we're starting to model, there's this implicit requirement for what does it mean to be good? What's the objective or goal? And how we define good and what those metrics are for measuring good, then determine what's the best solution. So, if you've ever been, I'd like to start with this picture. What do you see? I heard a frog. How many people see a frog? Do you see anything else?
Horse.
You said a horse? How many people see a horse? You may raise your hand since you're the one apparently. It's a horse. Anybody else see a horse? You see a horse?
Now that I was told.
Turn your head like this. You turn your head to the side. So what appears to be grass is the mane of the horse. What appears the legs of the, frog are the ears. This is the snout. The eyes. They share a common mouth, though. Horses, right? Everybody see a horse? Yeah. So we could be looking at the same thing, and some of you are going to see a frog, some of you are going to see a horse, but they're both there, right? So then that suggests that when I think about making decisions, what is good is in the eye of the beholder. And so we can be looking at the same thing, the horse and the frog, and come up with very different solutions for what is good and what's optimal, right? And so that means it's going to be critical for us to think about, our decision maker. What are their preferences? What are their priorities? What are their needs? And even if we take a step back from that, who actually are the stakeholders? Whose are we trying to capture? Because both the frog and the horse are there. So there's multiple ways to do good, right? And so when we talk about this, particularly in the second study, we'll be talking about, well, how do we try to understand what their priorities are when there are always multiple objectives in everything that we look at? So I'll start by learning from data. This is a picture. It's a patient. This is a patient who's been in the hospital about a day and a half. The blue line represents their systolic blood pressure. The green represents their heart rate, and the purple is respiration. And there's certain conditions for which something's wrong. Like if the systolic blood pressure drops below 90, it's a problem. If the heart rate is less than 40 or greater than 130, it's a problem. If the respiration rate is less than 10 or greater than 28, it's a problem. What do you notice about this?
Some little bit changes.
Jane, I heard like, murmur. It sounds like a class, murmur, murmur. Something else.
Jeff said that morning.
Right?
Yeah, bad times. That's
Around 8 o'clock, it looks like something different started happening, right? And there seems like there's something going on, right? Actually, around 8 o'clock is not that really, things are going wrong with the patient, but it's also that they're starting to get worried, and now they're starting to take observations very rapidly because they're actually starting to intervene on this patient. So you notice that not only these little triangles get closer and closer, so there's more and more monitoring happening, more and more intervention. So for this patient, at 1:30 in the morning, and this is rapid response team. So like rapid response teams are people with ICU training who might get called to the bedside. This patient almost met the criteria. Like if their respiration rate was greater than 28, they would have met it, but it was exactly 28. So they were close, but not quite. Then at 3:50, something bad happened. There was a clear change where they met the criteria. And you notice how the blue and the green switch. So if you ever stand up really quick and you feel dizzy, that's like the blue and the green switching. But this is a patient lying in the bed doing nothing. So for it to happen to them is a really bad sign. okay? And then around 8:29, they bought the rapid response team was called and brought to the bedside. So that's like 7 hours from the time when they almost met the criteria, and close to 5 hours from the time when they did, and they actually got help. Why do you think that happened? I know a lot of you work in healthcare. Why do y'all think that happened? Is it an anomaly? So,
Come on,
nobody knows, right? I mean, probably no one intended, right, for this to happen, right? That you know, they meet the criteria and nothing happens. We do know, like, at 8 o'clock, typically they're like rounds, right? Or people come together and like there's a change of shift. So like we're now looking at what the state of the patient is, right? So that might be part of it. The other part of it might be like maybe they don't have the luxury of like us looking hindsight is 20/20. It's amazing, right? To look at this all together and actually that all clicked. And then we don't know what other patients were there and what was going on with those patients, right? We can tell that the data itself does tell us a story. And it tells us something where we can try to look a little bit further. That work is what motivated a large-scale project we called sepsis. Sepsis Early Prediction Support Implementation System. I like to say that it's all in the title. Once I have a title, then I can write a grant. We almost believe once we got sepsis, that got us funding. So this is a collaboration from NC State, Mayo Clinic, Christiana Care Health System, and then it evolved to being MedStar, Drexel, depending on where people moved. I love Jean Huddleston, who is our collaborator there. She's a hospitalist who felt like they could be doing better, and so she went back and got a master's degree in industrial engineering. So you gotta love that. So one of the causes for those patients to deteriorate in that way is sepsis. Sepsis is basically the body's inflammatory response to an infection. It's like the body, as it's trying to fight an infection, it begins to fight itself, and organ systems begin to fail. Some patients for whom are fighting an infection will just recover, and the body can recover. Others, this starts to happen. It becomes very difficult for us to identify when that is the case until they reach a condition like septic shock, where it becomes very hard to go back without the patient either dying or having some major morbidity that remains after having this happen. Time is of the essence. Every delay increases mortality. It is also a very expensive condition, second only to joint and knee replacement in terms of hospitalized patients. Anybody who has an infection is at risk, regardless of how you got it. And it's complex because it starts looking like a cold or like an infection, and then it rapidly progresses, and all of a sudden organ systems are decaying. There aren't a lot of ways to define it well. We can use things like ICD-10 codes. The problem with them is that they're designed at the end of hospitalization, so it doesn't allow us to intervene early. We just know that's what they decided that the patient died of, or whatever the end result was. Clinical definitions tend to be vague in terms of, suspicious of infection. Okay, how are you? So it's hard to operationalize. So what we did was work with a clinical team to try to define what the first response would be to sepsis. We modeled this as an optimal stopping problem, okay, where we have this stochastic evolution of the patient's health. Basically, the patient is progressing through their natural history of health, and we decide which intervention to have. Anti-infective, which is essentially trying to fight the infectant that is present. Fluid was just trying to resuscitate the blood pressure. Which one should you do first, and how does it depend on the state of the patient, and then what happens to them in the end? We defined kind of this state space, fairly complex, as a function of different forms of inflammation, organ dysfunction, and whether or not they were in septic shock, as well as the location and what happened to them in the end. And we're looking at these three actions, and we define this reward function. We try to define what do we mean by good. For us, our state space was a function of features of the patient that we could observe over time, and observe particularly in the electronic medical record. So we took 540 vitals and labs, representing things like the creatinine, kidney function, respiration, temperature, systolic blood pressure. We worked with our clinicians to define, well, what did it mean for them to be bad? So we defined 2 types of inflammation, cellular and physiological, and then bounds on what we would look for in the EMR to define that something had gone wrong. Similarly, we looked at 7 organ system dysfunctions, and they're defined with them what it would look like if they were bad, based on what was monitored. And then we defined septic shock and defined what it meant even in absence of intervention, because actually it had been defined in terms of whether you intervened, which is kind of like circular, right? Like if you intervened, what if you didn't intervene when you were supposed to? And then we looked at the location and where they were discharged. We modeled this assuming that it was a continuous time Markov chain, Markov process. And if you think about this as one patient who went from having no physiological inflammation to physiological inflammation, of all the patients for whom this happened, on average it was close to 70 minutes between that transition, and we observed 16 of them. Okay, we used those to then model these episodes of care in the transition. So in particular, we went from admission and looked at where did the patient move. Nurse was what they call general floor in our data. And then we looked at whether they were discharged to home, to some other place like assisted living, or did they die. We started with about 10 million observations, representing close to 89,000 patient visits, about 15,000 unique patients. We filtered some out for things like left without, approval, authorization. And then we looked at what did they do for these patients? How many had anti-infective course? How many had fluids? And then we sought to create a control group. Like, what's the natural history of this condition? Well, as it turns out, kind of as you would hope would be the case in a hospital, only 6 patients had some condition that wasn't responded to. And so we had to define a natural history. And that natural history we defined in collaboration with our clinician collaborators in terms of patients who had such a delay in their intervention, it was like they didn't receive any care at all. And so we defined that both on 2 dimensions. One, for whom that happened at admission, so they had the symptoms, but there was a significant delay in their care. And for the more complicated patients are those that develop sepsis during hospitalization, and defined it for both of these groups. We were then able to identify about 678 visits for whom there was some delay in intervention out of the 53,000 visits. We formulated this in terms of a continuous time Markov process. You can kind of tell that typically patients spend the most time in staying where they are. There are more observations in the ICU and step down because there's more continuous monitoring happening in those spaces. And similarly, how they move around. And then we have kind of absorbing states, whether once you intervene, so it's a stopping problem with fluid or anti-infective, we stop, and then they're discharged and whether or not they leave the hospital deceased. We defined and assumed this was exponentially distributed, so we assumed continuous time. Interestingly though, on a similar project where we're looking at not just sepsis, but patient deterioration, the distribution of that data did fit in exponential, so we don't think this was a terrible decision. For each of these, the data kind of reduces even further because we've actually got to have a match between the natural history, the anti-infective, and the fluid states. So now we're down to like 3,500 states where we have all 3 matrices. We had to define what do we mean by good and what was a value function. We looked at the discounted expected infinite horizon reward, and we had a discount rate and the 3 actions. We define our immediate reward with respect to the cost of an intervention. So like if we did this intervention, what's the worst that would happen if it wasn't needed? And then in terms of how much time you spend in each state, and we defined a penalty associated with time spent in state. And what happened in the future because of the intervention you did. And so we assume that being more like an absorbing state chain, and what's the expected time to absorption and where did you get absorbed. For simplicity, we assigned a cost. Basically, the number of organ systems that are failing, the more you have, the worse it is. But we counted them as all being equally valuable, right? We also made sepsis worse than septic shock, worse than everything else. Different locations and different, we had a value associated with the location that you were in within the hospital, and then whether or not you had fluids or anti-infectives. As I said, we estimated the remaining health costs after intervention or without intervention based on the time to absorption following that. And this is what we saw. For the patients, okay, here we have the location, the ED, the general floor, ICU, or step down. Red means that anti-infective was first, blue means fluid, green means weight. Probably the most interesting thing that we found is that, you know, location matters. What you do depending on patients, for patients who are in the exact same state, it will differ. And in particular for our clinicians, they found it interesting that for the ED, for example, where patients could come in kind of sick or not very sick, this was one way of kind of differentiating those that needed intervention sooner than those that didn't. Okay, the other things kind of were more expected. And patients who were in the ICU and step down that were sicker, we would intervene for them earlier. It also mattered which organ system in terms of which thing you did in terms of fluids or anti-infective, and then when you waited, and as well as the location. And so, okay, that's what our optimal solution said. So we wanted to get a sense of, well, how did it compare to what they actually did, right? So if we take a patient and we map out their health state, then we tracked, you know, for every health state, at what point would we have intervened and when did they intervene? And we looked for those patients to see, well, what is the expected result in terms of the intervention depending on when it occurred. We found the following things, that typically our optimal policy was more likely to treat in the ED than what they were currently doing. In general, although not all the time, our optimal policy was more likely to reduce the probability of death compared to what they were doing currently, and was doing so basically because we were treating sooner than the current process, and in particular we were treating when there were fewer organ systems that were dysfunctional than the current state. And so we performed a little bit better. Some conditions, they were better than we were, but we had this kind of general trend. Now, this is not perfect. There are many assumptions we made. First, in terms of the reward function, we assumed it, right? We assumed all organ systems were equal. Maybe they shouldn't be, right? But it gives us a starting point to be able to learn, like maybe there's certain systems that are worse, more likely to decline than others, and things like that. And so, you know, the biggest limitation is natural history, which makes sense. This idea of at least being able to define a delayed patient population helped us to be able to say, okay, these patients should have received intervention earlier. They're kind of like as though you didn't intervene. What happens if we had intervened earlier? We had censoring. Some in the ICU, they happened to, their first place that they got an electronic medical record was the ICU, and so the people who provided the electronic medical record, they gave them control of their ICU data. But they learned for future EMR. And then I mentioned we made these cost assumptions. The more we try to personalize, the sample size gets smaller and smaller and smaller, right? So if I want to start saying, okay, what about the patients who have comorbidity? What about those who have hypertension, diabetes? Should they do the same thing? Is it the same? It gets smaller and smaller. This is with everyone, all in a group. And hence, there's uncertainty, right? There's some places where the transitions were rare, right? And so I'm putting a lot of weight on what was observed. How do we think about like uncertainty in those? Ideally, information should age over time. State space grows even more complex if I do that. As it was, a state space is like 60,000 states, which then you have to think about how do you communicate this meaningfully to a clinical audience so that it has value. What should the discount factor be? The organ dysfunctions, some of them could have very old information. And so we used a method of like carry forward. which is what they preferred, in that using what was the last thing known for their decision-making, they didn't even want us to like decay it. And there's complexity, right? This state space was very complex, but maybe all of those states don't have meaning. Can we think about ways to structure them and reduce them? So like maybe some type of, PCA or logistic regression as a way to like really capture those states that matter instead of keeping them all. But all of that adds to opportunities of things that we can move forward and do next. Okay? Any questions?
I have a couple questions, Julie. So I thought you would capture the personalization with the natural history somehow, like say a patient with a certain age and certain conditions, that's part of the natural history, did I understand that? Or-
It is, except for like, so we take all the patients and we define like their health is defined as this vector of, physiological, the forms of inflammation and the organ system dysfunctions. So, but I could personalize more, right? Like if I had looked at, say, whether or not you had hypertension beforehand, whether you are a surgical patient versus a non-surgical patient, that vector might be the same, but maybe the way that states progress would look very different for those patients. And so right now we took a ball and we said, okay, the thing that personalizes you is your health state, right? This collection of organ system dysfunctions and inflammation and where you are currently within the health system. So it's like personalization, but not to the level maybe it could be.
Second question.
Okay.
Sam, so you are tracking in the data, you're tracking sort of, it seems like you're tracking pretty frequently, and then you sort of went through a rate matrix, right, for the continuous time. Is that, you're sort of trying to capture those dynamics of like that morning, at some point with the, is that?
Every time new information is gained, we update our health state. That's why it's continuous time. So there aren't discrete episodes where we look and say, okay, every hour this is the case. Every time information is added, so it could be a few seconds, it could be several hours. And so that's the reason that we use it at continuous time. And so it's like every new piece of information, we look to see, okay, now has this state changed or not? Yeah.
Julie, do you have a false positive cost of intervention, but the intervention has a side effect? I mean, what do you have it in
So
your
what
work
we
function?
have in there is we have a cost associated with the intervention. What we did is we varied the costs, because that was very hard, right? Because sometimes it's like, oh, just give them fluids. What's the bad thing gonna be? Or give them anti-infectives. By the time you observe what the negative is, we're never gonna see it. So what we did is we took, they recommended this range from 5% to 40% of the worst cost in terms of death, and we varied that, and then used that as the penalty for having the anti-infective early or having the fluid infect early. So that we could basically say that, it's contributing, like if you do have too much fluid, it is actually a bad thing. And that's how we kind of put in that kind of penalty associated. We did something similar for certain locations. So, this is kind of starting to learn from data. Now let's talk about good is in the eye of the beholder. So we're going to transition to another topic. This work is work on with food banks. This project is based on a couple of projects. One of them is Feed, Flexible, Equitable, Effective, and Efficient Distribution for Hunger Relief. Got that? Okay, this is a collaboration with Hiram Urgut, Tanzid Hasnain, who was one of my former students, the Food Bank of Central and Eastern North Carolina. And we're trying to understand basically how do we think about optimal distribution of donated food? Food insecurity is a significant problem. It's always been a significant problem. It's actually only getting worse right now. So I feel like this is such a rich opportunity for our community to impact our world. Just put a little plug. Right now is a really good time to do it because there are significant budget cuts from like USDA that are impacting hunger relief organizations, food banks, and the Emergency Food Assistance Program. So they need people like us to the extent we can. So about 1 in 10 people globally are food insecure. Food insecurity is not equitable. We know that while 1 in 9 people in the U.S. Struggle with hunger, for children that's 1 in 7. So it has a significant impact based on age. We also know that it differs based on race and ethnicity, where Black and brown populations have a higher rate of food insecurity in our country. It's also not one size fits all. It differs quite a bit depending on where you live. Feeding America looks at where you live based upon your county. And so if we look at food insecurity by county, the darker areas have higher food insecurity rates. So you notice like the southern parts of the US, Alaska, have significantly higher food insecurity rates. In face of all of this food insecurity, we have a tremendous amount of waste also. About 30 to 40% of our food supply is wasted. That translates to 130 billion meals. And it costs $480 billion of food is thrown away on a regular basis. And some of it has to do with getting the food that people want to the right people at the right time in the right space, right? And so this is a significant logistics problem. Like historically, people think of food insecurity as based on lack. In the US, it tends to be based on logistics. We might start with the reduction in some of the money. It might get a little bit tight in some other areas, but we've worked for probably about 15 years now with Food Bank of Central and Eastern North Carolina. They serve 34 counties. They have the following structure where they take donations from national and regional sources. They go into a hub that's in Raleigh, and they have 6 branches where Raleigh is both a hub and a branch that serves one of the counties. And then from those branches, local donations also come into this system, and there's transshipment between branches, and then those branches distribute food to our food insecure neighbors across these 34 counties. And that they do that through a network of partner agencies, about 800 partner agencies that are food pantries, homeless shelters, school lunch programs, and that's how food reaches our food insecure neighbors. We've studied this problem a lot, and we kind of tend to think of them having these 3 objectives that they're struggling with. One is equity. They have this belief that, they want every county to receive a fair share. While we can't satisfy anybody's complete need, they want everyone to get something. And so this fair share model is how they've worked. Maximizing food distribution, so we want to minimize waste. Minimizing the cost of distribution, so we want it to be efficient. So like perfect equity, everybody receives their fair share, all food is distributed, and we do it in the cheapest way possible. Obviously, these different criteria have trade-offs, right? So if I distribute food equitably, it's either going to mean that I have undistributed food, or it's going to be costly, because it doesn't cost the same to distribute to my rural counties as it does to my urban counties, or those counties that are close to the branches. If I have perfect effectiveness, that means I'm going to distribute all the food. I can do it in a way that's cheap, so I can feed it to the closest places, or it's going to cost me, okay? A efficient solution is always don't distribute anything, somehow defeats the other purposes of the organization, right? Or it could be inequitable, is another way to be cheap, or you have undistributed food, okay? So there are these trade-offs that are present. When we look at what that looks like, so if it were equitable distribution, the density or shade of the color would be kind of the same regardless of where you are. And these are just their different branch locations that differentiate the color. If you wanted to, distribute everything inequitably, you just send it to the closest to the branch location. If you wanted to do it cheaply as possible, but distribute everything to every county, it's going to be inequitable. And actually, this would be, cheap as possible. This is perfectly equitable. This is what they actually do, right? So it's somewhere in between, right? That they're not able to be perfectly equitable, and they make sure everybody gets something, okay? And we know that what they do differs over time. So from one month to the next, the pounds of food per person in need, so this MPIN, ranges from 3.6 to 15, or in October, where they had 2018 massive hurricane, it was 5.6 to 49.6. And so we know that in certain areas receive more kind of relative to what's going on that month or that time period. So our questions were, how do we capture the trade-offs between equity, effectiveness, and efficiency? My student adopted my acronym thing. He called it Model Triple E. And then how do we identify what those preferences are over these three criteria in a way that we don't have to interact necessarily with the food bank? And then what impact does it have on distribution decision-making? So this is a multi-criteria decision problem, right? And often when we think about those problems, it really depends on what weight we put on effectiveness, efficiency, and equity in terms of what's a good decision and what's the best decision, right? We have constraints on, we take hub to branches, we have transshipment branches to counties. And first, we have to consider the units, we have to consider the scale, and then we have to consider priority and preference. So for us, we define equity relative to the pounds received and the fair share, like their proportion of what they should have expected in this context. We define effectiveness in terms of basically a holding cost for what's left over and not distributed. And we define efficiency relative to the cost to distribute throughout the network. We scalarized everything in the following way, kind of defining what it meant to be worst case equitable, efficient, and effective. And for each of these, we solve with multiple decision variables for lots of different weights, okay, to see, okay, based on that, what should we do? And so we looked at about 1,200 of these various weights and saw, well, what impact did it have on distribution? And it looks something like this, okay, where the x-axis is the weight on equity, the y-axis is the weight on effectiveness, and we have these different regions. So like the blue region means that everything's distributed equitably, and we distribute everything. Orange is like it's inequitable, we distribute everything. Red is an area where you wouldn't distribute anything, and that would be the optimal, and then green is where there's partial distribution, right? And so what we know from this is that, okay, the weight matters, all of them don't matter, right? There's regions for which you do one thing versus another, but the weights do make a difference, right? So if I'm in the blue, I do one thing. If I'm in the green, I'll do partial. And then if I'm in this other area. So then it's really important for us to be able to say what makes a good decision, to have some understanding of what the preferences are actually of the decision maker. And for us, the decision maker was the organization. And so we wanted to learn, based on what they did, what their priorities and preferences were. And so we defined this preference elicitation algorithm, where we start off and we assume that what they are doing is what is optimal for them at this time, or what their priorities are. And so we take the current distribution and we calculate what the effectiveness, efficiency, and equity are associated with what they have actually done. Then for that current period, we look at varying the weights for each of these. We solve the algorithm for under each of these weights and scenarios, what is the equity, efficiency, and effectiveness associated with that weight? Then we look and see, well, what's the difference between what they actually did and this value for every parameter, with the goal of trying to reduce ourselves down to having a single weight combination, down to like some epsilon, right? Do we get down to 1? No, never. But instead of having 1,200, we get down to quite a small number. And so then we're able to get a sense of, okay, for their actions, what does it actually translate to in terms of what weight they're putting on each of these criteria? And so when we look at, distribution associated with 2 different months, we can see that there were different things that they did. They distributed and had different remaining inventory levels. We had different distribution costs associated with those 2 different months, the timeline. And then we looked at, okay, based on our PE algorithm, where were their preferences that align? So instead of having 1,200, we could get it down to 3. And we could see that their weight on equity ranged from 0.29 to 0.4. They put the highest weight on efficiency, lower weight on effectiveness, lowest weight on effectiveness. Now, interestingly, I told you we've been working with these people for like 15 years. What's the most important thing to them? we only care about equity. Equity is the most important thing to us. You worry about cost, it's not about cost. It's about equity. 15 years. We show them this, and they're like, well, it does matter how much it costs. And, you know, they're like, that does seem, yeah, that's about what we're doing. And so it's not like us asking them their preferences. They couldn't tell us their preferences, right, and their priorities. These are abstract concepts. So the ability to kind of at least let their data tell them what they're prioritizing gives them also the opportunity that if in fact they didn't like this combination of weights, we could give them direction on how you might have distributed differently to align with the values that you wanted, right? And so it allows us to kind of help them think through what their actions translate to relative to what they say their values are. Now, admittedly, you know, they have a budget, although they've always told us they didn't care about it. Clearly they do, you know, and then we can also see that, you know, at different times of year or different time periods, we're actually even able to get like closer and tighter depending on what their distribution actions are. And so, you know, this allows us really to get a sense and say, you know, for your future, this might be what you should do. So, yeah. So there were lots of insights for them. One, we can tell like these ranges, right, these regions that they fall within. We, you know, give them a sense of, you know, which criteria are they favoring? How are they favoring them? They can figure out, you know, what's the cost to achieve what they want to achieve, you know, relatively speaking. And then, you know, how their preferences actually are aligning with what their priorities are. And maybe those preferences aren't the same every month because there are holidays or other periods. Food insecurity is not static, it's dynamic, right? And so this allows them to look at those things. Lots of opportunities for future direction. You know, everything we assume these, you know, I love things being stochastic and dynamic. We assumed everything's deterministic, right, as a starting point. Obviously, there's opportunity for stochasticity, opportunity for thinking about multiple horizons, trying to consider things around capacity and understanding the actual capacities at the different levels, and also the fact that it's uncertain, incorporating that in the model. We're doing some work now looking at, well, how do we measure effectiveness or equity? What is equity and how are we measuring equity? Is it the best way? So we have a project that we've been working on for a couple of years, satisfying households in areas with food insecurity and a network of good sharing. And this is like a collaboration between NC State, A&T, University of Alabama, University of Michigan now, and the food banks that are in each of these areas. So like the Food Bank of Central and Eastern North Carolina, Second Harvest in West Alabama. And then we collaborate with partner agencies, the local pantries at each of our universities, as well as other agencies. And we're looking at basically this getting from food rescue into food insecure neighbors' hands. And like, it's a collaboration across IE, management, computer science, and civil engineering. And so, you know, as we look at our models, you know, we always want to ask questions, you know, are models answering the questions we ask them? They do what we tell them to do. Are we asking the right questions? I think over the evolution of my career, I'm asking myself that over and over again. Right now, we're really asking ourselves that question around equity. Like, we've done this fair share model. Is that really the answer? And what are the implicit assumptions that we're making relative to that? And what are the consequences? And so we've been looking at things around equity. I'm not going to talk about this because I'm pretty sure I'm at time. I heard things zipping up, so that makes me, you know, but we kind of have looked at things like, in particular, minimizing maximum regret versus a fair share model and what impact that has. And some of the things that we can see, right, is that, you know, if everybody has the same need, there's no difference. But the minute that there are differing needs, we should do different things. And what those things look like, really, is actually trying to get up to a level where we have the same unmet need. So once we have enough supply, like we have infinite supply, we can give everybody what they need. But the minute we don't have infinite supply, what we need to do is start getting people up to the same unmet need, right? And once we're at the unmet need, then you can get your fair share, right? And so basically that's what we've been able to see using kind of minimizing the maximum regret criterion is doing something exactly like that. And then now we're kind of looking at this weighted, multi-objective, fair share, minimize regret, because, you know, nobody wants anyone to get nothing. So like, how do we kind of make that trade-off so that everybody gets something, but still thinking about the fact that there are inequities? And we've looked at this, like here we're looking at it around race, ethnicity, but we also are looking at it around things like age, geographic areas. Like we know southern regions have higher food insecurity. And so that's kind of what we're looking at. And okay, so, you know, as we kind of think about this idea, like I feel like we're people that can make the world a better place. I already gave my pitch for like food insecurity and things we could do, you know, but when we do that, there's a lot of responsibility. And I think as we see a world with AI, it's even more important. Like, how are we interrogating our models? How are we interrogating our solutions? Are we asking ourselves hard questions around our models? Like, do they address the needs of the stakeholders? There are lots of assumptions I make that make the model solvable that may not be relevant to the stakeholder, but like there's a trade-off, right? And what are their limitations? I'd like to cite like Shannon Harris's work, where basically she looked at no-show penalties. And while we, you know, that's like a born OR thing, let's penalize people for no-shows. What she found is that disproportionately it impacted some populations more than others. And in doing so, instead of like getting the behavior where people showed up on time, people just didn't go. And so they weren't getting their care, and you're disproportionately impacting certain populations with that penalty, that type of penalty. And I always like to quote Destiny Knock work, you know, as we look at our models, it's really imperative when we look at our solution to say, who is hurt the most by our solution? So if we look at that then, and we go back and say, let's do a feedback loop. How do I figure that out? How do I address that with my constraints, with my structure? How do I think about that? So all of this work involves partnerships with different people and lots of people like my students who I love to death, so I always like to show them. I learned at Informs this year that my students, they call them the Ivy League, so I'm all into that name. Someone told me that, I'm like, oh, I love it. But, you know, all of this work couldn't be done without all of them. So I'm just a representative. So thank you for having me.
Thank you, Julie. We got quite a bit of time for questions. Go ahead, Rob.
So I'm interested in equity, and you have these multi-factorial measures of equity. Have you thought about how you communicate to your stakeholders that in fact they're receiving an equitable share?
So this is part of what we started to do, where we're looking at these multiple measures, because like our fair share measure, that came actually from our food bank partners. Like that's been their criteria for years. And we've been like, okay, fair share. And then as we've looked, we said, okay, well, it implicitly assumes that everyone has the same unmet need, right? That just the rates of food insecurity are different, but not the need, right? And so if you at all, like those little, so we're trying with those little bars to at least show them what happens. The fact that when I give you your fair share and we don't have the same need, I'm just propagating and continuing the disparity. It's not gonna reduce, right? But your goal was to make sure everyone got something, right? And so what we're trying to show with this minimizing maximum regret is that you've got to actually bring everybody up to a level, right, before you can start doing their fair share, right? Now, I will say, part of why we're starting to look at this type of solution where we weight the two of them is because it gives people a really bad feeling to think that somebody wouldn't get anything, right? And that is what would happen if in fact you had to bring people up to the same level of unmet need. And so we're trying to show people what that trade-off would be. Now, I will say, depending on what metric we use, like when we use race and ethnicity, that becomes a more challenging discussion. when we use geographic things, people are better able to like look at that exploration.
So equity is an objective measure when you use those criteria, but have you tried to close the loop? I mean, equity is a perception, and do your stakeholders perceive based on the distribution that they've got their fair share, their equitable share?
So, in terms of the agencies feeling like they've gotten their fair share, we've just starting to talk to the agencies more. I'll say that most of our relationship has been from the perspective of the food bank, telling us about the agencies. As we talk more to the agencies, some do not feel like they've gotten their share. Some feel, and like we did this actually during Hurricane Florence, where people felt like certain areas, certain groups got control of food and distribution, and they felt like others were not included. We don't have a solution for that, but we do know that there's this feeling, and in fact, like we're starting to do some work where we're thinking about like how should the network agencies actually collaborate with each other to make the network more resilient. And so we're trying to understand like people's willingness to partner, the agencies, and we discovered, and we never had looked at the data this way before, that there are certain agencies that are, like we knew some were stronger than others, but there's some who get a significantly higher proportion of food than others because of their infrastructure, really, their ability to receive it. We're just starting to communicate that to the food banks, and they've, like in some sense, they've empowered those agencies more, and they trust them to actually operationalize to a lower level, but that infrastructure may not be in place for them to collaborate and operationalize it. So I don't know that I answered your question. I just can tell you what we've been learning right now and giving insight.
So how did you handle the different scale of those criteria?
Yeah,
So some use the pound of food, some use the holding cost. So
Yeah.
how you make the number?
That's what we do. We do like the scale. We do a scalarization, and where we basically scalarize everything relative to the worst case minus best case kind of denominator. And so now every variable is like unitless. In order to do some of the solution for like what the worst case scenario was, we actually formulated some mixed integer program to solve for what the worst case would be. One struggle we have there, I will say, is that there's a difference between like potential worst case scenario, like when we scalarize, and realized worst case scenario. So then we've had to look back and try to figure out, and this is something we're struggling with actually, is that what is the actual worst case may never be realized anywhere near to it in the data. So then you're automatically biasing, right, by scalarizing with that. We tried to do this realized worst case, but that is not it is a work in progress, because that actually it can end up where we have counter examples that happen. But yeah, one of our challenges, so we scalarize is how.
So you did not consider to convert everything into dollars?
No, because there isn't a clean conversion for that. Yeah. And also scale, sorry, it's not just dollars, it's scale. So like, you don't want, like, even if I could convert everything to dollars, some things are very different. Like equity is a different scale, right? It's a unitless measure, so that would be a challenge, yeah.
So going back to Rob's question about equity, I wonder if the needs are constant across counties, and if they're not, whether reciprocity would play into that. So you may not have gotten your fair share this time, but you will get more later because your needs change.
So they're not constant over time and across county. So geographically or over time, they're not constant. That is something that they kind of operationalize. They will eyeball and say, well, you got a lot more, like certain counties are perceived to get like a lot more donated food or dry good food. And so then they try to make it up in the next month.